Okay. Can you all see my screen?
Yes, we can.
Okay. Thank you. Thank you very much. So I will start sharing. I think I've been introduced already. Thank you very much for the introduction. And thank you to the organizers for this opportunity to share. So, as you have heard, I'm a clinical consultant working in the Department of Oncology at Parenyatwa Hospital, which is part of the teaching hospital of the University of Zimbabwe Medical School. So today we are going to learn about the current cancer treatment protocols. We'll also discuss the recent advances in oncology, and we'll explain the factors that affect cancer prognosis. Then I will touch on cancer survivorship and I will identify strategies to improve survival, as I was asked to also look at that. So generally in oncology, every patient deserves not only longer survival, but also a better quality of life. There is generally a belief among people that cancer is a death sentence. But that is not true. Cancer is not a death sentence. Yes, cancer is a life-threatening condition, but there are some patients who actually receive treatment for cure, and some patients respond very well to treatment. Whilst we acknowledge that the prognosis is different in the different types of cancers, we should also strive to make sure that every cancer patient gets a good quality of life despite their prognosis and the cancer stage that they have. So, in general, cancer is a growing global burden. We see that there are nearly 20 million new cancer cases worldwide. And of these, 70% occur in low and middle income countries such as Zimbabwe and other countries like Zambia, Kenya, Rwanda, Malawi. We expect that the cancer cases will be rising in these countries since they are in the low and middle income range. So Africa is expected to experience one of the largest increase in cancer burden over the next 10 years. Um, this is just a graph depicting the numbers that I have alluded to, showing that the cancer burden is expected to rise. So, going on to cancer survivorship, what really is cancer survivorship? In June, we commemorate the survivorship for patients cancer. So, what does survivorship actually mean? In cancer, survivorship is an ongoing experience of living with the disease, through the disease, beyond the cancer, up to the time the patient dies. That is what we call cancer survivorship. So take note, it's not just the moment from when a patient has been told that they are cancer free, but it's actually the time from the diagnosis of cancer up to the time the patient dies. And it does not only include the physical well being of the patient, it also includes the mental, emotional, psychosocial, spiritual, and financial effects of the cancer. So it involves earlier diagnosis. If we want to improve survivorship, we have to work on earlier diagnosis, better treatment options and outcomes, fewer complications, financial protection, and access to long-term survivorship care. Um, this is just a diagram showing the aspects of cancer survivorship that I have been talking about. So the physical symptoms, the economic impact, factors that affect disease recurrence and development of new disease, as well as quality of life, healthy behaviors, and psychosocial care. So it's a continuum of care. It's not just looking at one aspect of the cancer treatment. And what are these cancer treatment modalities? I know you're all aware that cancer is treated with several modalities. Most cancers do not require one modality of treatment. Where we know that we are not going to get clear margins. By clear margins, I mean to get a representative amount of clear tissue which does not contain the cancer cells. And sometimes we offer surgery to palliate symptoms. So there are also advances in surgery, which include robotic surgery, image-guided surgery, sentinel node biopsy, and minimally invasive surgery. So there are many advances in surgery these days. So approximately 50 to 60% of cancer patients will require radiotherapy at some point in their illness. So this is whereby us as radiation oncologists come in. And there are modern treatment techniques which are now in place. Back then, we just dimensional radiotherapy planning techniques, but now we are using advanced techniques such as 3D conformal radiotherapy, intensity modulated radiation therapy, VMAT, image guided radiation therapy, stereotactic body radiotherapy, and radiosurgery. We are also using AI in planning the treatment. We use AI assisted contouring. We have adaptive radiotherapy and also proton therapy. So proton therapy is a form of radiotherapy whereby we are using protons to kill the cancer cells. This is a very expensive treatment which is not readily available in most African countries. I know in the northern countries like Egypt it is available, but in sub-Saharan Africa we do not have any countries that have this modality of treatment yet. What are the benefits of radiotherapy in cancer treatment? They offer high cure rates with preservation of the organs at risk, less toxicity, and a better quality of life. The take-home message most cancer patients is that most cancer patients will require radiotherapy at some point in their cancer treatment journey. Another modality of treatment is chemotherapy. This is whereby we use drugs that destroy the rapidly dividing cancer cells. So this chemotherapy is used it can be used in the neoadjuvant setting. Neo means before, so it can be used before we start the main modality of treatment, which could be surgery, it could be radiotherapy, it could be something else. So it can be used in the neoadjuvant setting. Adjuvant, this is whereby the chemotherapy is used after the main modality of treatment. So for example, in patients with colon cancer that are stage 3 and above, after surgery, they get chemotherapy so that we can kill any residual microscopic disease that may remain behind. Sometimes we use chemotherapy together with radiation. An example being cervical cancer. We call that concurrent chemoradiotherapy. We also use chemotherapy in the palliative setting, whereby we know that the patient has got an advanced stage of disease. We are not going to achieve a cure, but we want to relieve symptoms such as pain, ulcers, and things like that. So the advances in chemo is that now we've got regimens that are less toxic, and we also have better supportive medication to reduce the side effects. An example being the granulocyte colony-stimulating factor injections that we give to boost the neupogen or the granulocyte count in patients. We also use hormonal therapy. This is where we use hormone treatment for those cancers that are hormone sensitive. For example, in breast cancer, we may use tamoxifen, which is a selective estrogen receptor modulator. For those cancers which are hormone receptor cancers, we may use aromatase inhibitors. We may use things like fulvestrant and things like that. So we first of all test to see if this cancer is going to be hormone receptor sensitive before we give the treatment. Prostate cancer is another example. I'm sure you are aware of the use of ADT, use sertraline, leuprolide to make sure that we suppress the testosterone levels so that we prevent the prostate cancer from growing. We also use second generation anti-androgens such as abiraterone, enzalutamide, apalutamide. So these are just a few examples. The list is not exhaustive. There are many other cancers where we check their hormone sensitivity, and then we use hormones to manage or control the cancer. Then we also have targeted therapies. So these have also come up where we target specific molecular abnormalities that are present on the tumor cells. So we develop a medication that targets those specific molecular abnormalities. Examples include HER2 inhibitors, EGFR inhibitors, ALK inhibitors in lung cancer, PARP inhibitors. We can use them in ovarian cancer, in breast cancer, BRAF inhibitors. Also in melanoma. So the advantages are that they offer precision treatment with a better response and also reduced toxicity generally compared to chemotherapy. Immunotherapy is whereby we are harnessing the immune system to fight cancer. So these include your PD-1 inhibitors such as pembrolizumab, your CTLA-4 inhibitors. We use them in cancer such as melanoma, lung cancer, breast cancer, renal cancer, even in cervical cancer. We also use immunotherapy. So in summary, I'm saying we now have precision oncology, whereby we are offering the right treatment for the right patient at the right time. This is just a diagram. Very much simplified, showing what precision oncology means. As you can see from that diagram, you can obtain a sample from the tissue or blood of the patient. You analyze that using molecular profiling, biomarkers, next generation sequencing. You identify specific targets, and then you offer treatment which is tailored to those targets that you would have identified. You give the treatment, you monitor the patient, see whether the cancer is responding, see whether there are any side effects that need to be adjusted. So that monitoring ensures that the treatment remains effective, and also it can be adapted over time. The benefits is that it's more effective, it has lesser side effects, and it has better outcomes. On the side effect, these treatments can be very expensive and maybe beyond the reach of some of our patients that we see in the local setting. Then let me move on to the next slide. We also use AI. I think I've talked about AI. Nowadays, it's used in screening, diagnosis. Pathologists now use AI to improve their diagnostic effectiveness in certain cancers. Of course, this has to be used in centers that have got the experience of AI, as you are sometimes may interpret it wrongly, so this needs training. But if it's used correctly, it improves speed, it improves accuracy. AI is also used in treatment planning. I told you about its use in radiation oncologist, where we use it to assist us in contouring. It can contour the organs at risk. It can contour the tumor volumes. It also assists in clinical decision support. So generally, if used correctly, it can reduce the workload. Moving on to what we started on precision oncology, current advances in oncology, we talked about AI, radionomics, theranostics, whereby we are combining diagnostic imaging and targeted therapies for personalized treatment. Um, Copy tumor colony DNA monitoring, molecular tumor boards, whereby as multidisciplinary team, we sit together, integrate molecular data to guide patient personalized care. So there is a lot of new things that are happening in the cancer world, lots of treatment advances, lots of new drugs, lots of new things on how we can better manage patients with cancer. Um, then this cancer prognosis, what really does it depend on? So prognosis, when I talk of prognosis, I'm referring to the expected outcome of a disease. I'm sure maybe, I don't know if you're already going to ward rounds, but in some ward rounds, you hear us talking about counseling the patient on poor prognosis and things like that. So we are talking about the expected outcome of a disease. A patient with poor prognosis is where we know that the expected outcome of the disease is poor versus a patient with good prognosis where we are expecting a better outcome from treatment of that disease. So it focuses on things such as the overall survival, the disease-free survival, progression-free survival, local control, and quality of life. So it depends on a number of things in cancer. Not everyone with cancer has the same prognosis. It depends on the patient factors. So the age of the patient, how physically fit they are, we call that the performance status, their nutrition status, are they malnourished, are they obese, are they well nourished, and do they have any other comorbidities, the relevant medical history. So all that will actually determine the prognosis of the patient. Then we also have the tumor factors, cancer type. Someone with cervical cancer is different from someone with, for example, CA head of pancreas cancer or someone with melanoma. So the cancer type has a role on prognosis, the stage of the cancer. If it's more advanced, it's more difficult to treat, and you may need more modalities to manage that cancer. Then tumor biology, the molecular profile, and also the response to therapy. Some cancers generally respond poorly to radiotherapy or chemotherapy. For example, sarcomas versus carcinomas, their response to chemotherapy or radiotherapy is different. So there are a number of factors that affect the prognosis. Health system, is the patient access the care? Are there any delays in the diagnosis? How is the human resources in that area? Do they have access to radiotherapy? Are the medicine readily available? Are there any financial barriers? So all these things determine the outcome of a patient who has got cancer. It's not just one modality, but there are many factors which affect the outcome. So we move on to cancer survivorship. So we have said that cancer survivorship begins at diagnosis. So when we are now talking about cancer survivorship, we are talking about the physical well-being of the patient, as well as the emotional, social, financial, and spiritual well-being. So the factors that affect survivorship include those factors we talked about: prognosis, and then there are also treatment-related factors. Does the treatment have early or long-term side effects? Does the patient has psychosocial stresses? Is the patient depressed? Is the patient well nourished? Are they fit? Does the patient have access to adequate family support? And do they have access to rehabilitation programs? So, as healthcare centers, there are areas that we need to work on to improve cancer survival and survivorship. So, for survival now, remember, we are saying it depends. This survival and survivorship, it starts at diagnosis. So before the diagnosis of cancer, as healthcare providers, we need to make sure that we have got adequate primary prevention protocols in place. So things like vaccination. Are we vaccinating against hepatitis B, for example? Are we encourage people to be physically active? Are they exercising? Are they decreasing the intake of harmful substances like cigarette smoking and tobacco, which we know they could be cancer initiators and cancer promoters? So if we want to improve survivorship in a region, we have to start at primary prevention. We also have to improve screening and early diagnosis. Screening allows the cancers to be detected in their early stages. That way, we increase the chances of cure. Remember, we talked about stage of the cancer being a prognostic marker. Then also, we have to make sure that the patients have got access to timely treatment. The treatment should be available at the right time. And we should have access to multidisciplinary care whereby a patient is discussed by various specialists that manage that particular patient. So a patient with breast cancer does not only belong to the general surgeons or to the breast surgeons. There are other healthcare workers that also have to come into place. So these include the oncologists, the nurses, the palliative care specialists, the counselors. So there are a lot of people that are involved in the care of a patient. It's not just one doctor that is in place. So follow-up care facilities have to be adequate, rehabilitation facilities have to be available, and also survivorship programs. We'll talk more about that. So I talked about the long-term effects of cancer treatment. If we are to improve survivorship care, we have to ensure that we have survivors that monitor the long effects of treatment. We talked about chemotherapy, hormonal therapy, immunotherapy, targeted therapy. All those things have got side effects, which can include fatigue, sexual dysfunction, infertility, cardiac issues, surgery can cause lymphoedema, things like that. So survivorship care should ensure that there are facilities in place which deal with these side effects. Otherwise, the quality of life of a cancer patient will be compromised. There should be access to rehabilitation services like physiotherapy, occupational therapy, nutrition management, and there should be surveillance for cancer recurrence and new cancers. So us as oncologists, we make sure that we offer surveillance to these patients. In the first 2 years of treatment, we see them every 3 months. And then in their second to the 5th year, we see them every 6 months. And then after 5 years, we see them once every year. This is all just to make sure that we are checking out for cancer recurrence, development of new cancers, and we are monitoring the side effects of treatment and offering treatment to these patients. So we also in these visits discuss about lifestyle modifications such as a healthy diet, regular physical exercise, weight monitoring, smoking cessation, healthy sexual activity, management of comorbidities, and return to normal life, for example, return to work, return to school, and also counseling on the finances. So as healthcare workers who work in different health systems, we work with governments to ensure that there is investment in cancer centers with facilities that offer all modalities of cancer treatment. We encourage training and retaining of more oncology dedicated workforce. We encourage improving access to essential medicines. We encourage the strengthening of cancer registries, digital health, and also research. So there are many countries which have got what we call a cancer control plan. In Zimbabwe, we've got our own national cancer control plan. I know countries like Kenya also have these cancer control plans. So they make sure that there are policies and frameworks which enable healthcare workers to offer the proper treatment for the patient. So in these plans, there will be SOPs to say if a patient has got discharge, what do they do? Which center do they go to? What is their first port of call? Are there radiotherapy facilities? Are there radiology facilities for diagnosis? Things like that. So most African countries have got these national cancer control plans in place, which is a good thing that our governments are doing. Some countries have also moved on to the development of a universal health coverage. We have talked about some of these treatments, which are very expensive. Some can cost to the tune of maybe $5,000 every 3 weeks for something like that. So a universal health coverage will ensure that some of these treatments are affordable to some of our patients. There's also prioritization of financing. Talk of there was introduction of a sugar tax whereby some of the tax that is collected from sugary drinks is now being channeled towards cancer treatment services. For example, the procurement of radiotherapy machines. So this is something that we recommend the government for doing. We also recommend the government for ensuring that there's training and research for cancer. You will all acknowledge that most research in cancer patients was done in Western countries, and the population there may not correctly resemble the population that is in Africa. An example being that in Africa, most of our cancers are advanced stage cancers. In Western countries, they may not be so advanced stage cancers. So research in local settings is very important so that we know the correct treatment to offer our patients. Some countries have also protocols on effective medicine procurement, which is very important in cancer patients. Healthcare systems, we've talked about this. There should be timely diagnosis, quality treatment, patient-centered care, which is safe, offer research, and the healthcare should be able to also conduct clinical trials. Moving on to the civil society, as the civil society is encouraged to advocate for patients. I know in most countries there are some cancer support groups. There are some societies which raise money for breast cancer, cervical cancer. We all know of the Pink October, January cervical cancer month, prostate blue, things like that. So things like fundraising, they also assist in making sure that our cancer patients get the treatment that they need, and also reducing stigma. Some patients do not want to get treatment because of the stigma associated with cancer. So we have got a role to making sure that we demystify this cancer. In Africa, our challenges, the challenges that are still glaring include late presentation and limited access to some chemotherapy drugs, not all of them, and also to radiotherapy facilities. Financial challenges, we talked about that, but we note that some governments are working towards a universal health coverage that will help people with cancer. Human resource shortages remain a challenge as some oncology workforce move on to greener pastures after getting training in their home countries. So this is a challenge that we still have to work on in Africa. Opportunities for improvement include innovation of local solutions. I talked about research in our home countries, regional and international collaboration. We have a lot of regional collaborations. I'll just mention a few. We've got the African Cancer Care Network, the ACC. We also have the AfroNet. We also have AfroG. So we've got a lot of regional collaboration as countries in Africa. So this also enables us to network, sit down with ideas for patients in local setting. Telemedicine, research, efficient use of AI, all these help to improve the cancer treatment. This is just a picture of a WHO meeting where they were advocating for better access to cancer treatment, showing that there is power when we unite to come up with better solutions for our countries. The vision for Africa is that every patient should have access to prevention, diagnosis, treatment, as well as palliative and survivorship services in their home countries. Take-home message: cancer survival can be improved and is improved. Early diagnosis saves lives, and modern cancer treatments continue to improve outcomes. Take note: survivorship begins at diagnosis up to the time of death. It doesn't end when a patient has finished their treatment. They still need to be looked after in terms of those side effects I was talking about, financial counseling, returning back to work, things like that. Every stakeholder has a role to play. We are part of healthcare systems. We are members of the civil society as well. We can advocate for our patients so that they get better outcomes from cancer. We do not want cancer to be a death sentence. Yes, it's life-threatening, but it can be treated, it can be managed. Africa can substantially reduce cancer mortality through investment, collaboration, and equitable access to quality health care. So together, we can transform the cancer care in Africa. Thank you very much. I think I've exceeded my 30 minutes by 7 minutes. I think I'll end here. Thank you very much. I heard the presenter saying the questions will be entertained after all the presenters. So thank you very much for this opportunity. Thank you. I'll hand over to the chairperson.
Thank you so much, Dr. Edith, for that wonderful presentation. Yes, as I mentioned earlier, let's keep our questions for the session, Q&A session. Yes, up next, we're going to have our second speaker, who is Susan Katuruza, a cancer survivor, specialist renal nurse, and crochet artist. Sorry. Yes. So, Madam Susan, are you ready? Okay, so we're just having challenges with network. Let me just check if she's managed to log in. Okay, unfortunately, our second speaker is having network challenges, so we'll go to our third speaker. Then hopefully by the time our third speaker will be done, she'll be ready. Yeah, so up next, we're going to have Dr. Khelia Mahoro, who is an assistant lecturer in the Department of Primary Health Care at the University of Rwanda and a doctor trained at Badji Mokhtar University in Algeria. She teaches palliative care, professionalism, and health systems unites in the module of social and community medicine from first year to third year. Yeah. A round of applause for our second speaker, Dr. Khelia Mahoro.
Okay, thank you very much, dear chair of this meeting. I'm very pleased to be part of this audience and to be able to share my small contribution to this wonderful initiative. As you've said already, Mahoro Khelia, I'm part of the teaching team at the University of Rwanda in the College of Medicine and Health Sciences. And I'm in the Department of Primary Healthcare. And we teach the social and community medicine module where we talk about palliative care at the primary level in Rwanda. Let me try to share my screen. Let me know if you're able to see my screen. On my side, it's showing that I'm sharing.
Yes, ma'am, we can.
Okay, thank you. So it's not easy to do a presentation after such a good presentation by the previous speaker. But for my side, I'll go straight to the point to palliative care than at the health centers, at the district hospital close to the patient, to see how in Rwanda we are trying to decentralize our approach of palliative care. It means we don't only do it in referral hospitals, but we're now trying to have palliative care units in each district center, district hospital, to have it even at the health centers. And for some cases also to allow community health workers to play a role in the network of treatment. So my presentation is titled An Introduction to Palliative Care. We developed this content in collaboration with the African Center for Research on End-of-Life Care, IHCRI-Rwanda. We collaborate with Dr. Christian Rizimira, who is a pioneer in palliative care in Rwanda. And he's the director of that center. So usually, okay, I'll start with this simple sentence. from Hippocrates that says that it's far more important to know what person the disease has than what disease the person has. If I would talk to future medical doctors, students or interns, sometimes we tend to say the case with this, let's say a breast cancer case or a prostate case, instead of saying this person named XY with this disease. So it's important to remember that the patient we have has specific attributes, specific weakness and strength that will help him fight the disease, or that will help us as practitioners manage his condition. So in brief, even though the first speaker talked about it, I'm going to do a small reminder about what is palliative care. So the aim of palliative care, it is to provide a better quality of life to patients and families who are facing a potentially lethal disease. Prevent when possible and treat when possible the symptoms. So sometimes the symptom, as they said, can be curable, and sometimes we are just in decreasing their effect and helping the patient have a support system or pain management. So the symptom control we are going to talk about is both physical, so pain management, but also psychological and spiritual support. And when we talk about psychological and spiritual support, we don't only think about the patient that we are having in front of us, but we think of his caretaker, his family, and the person who are working daily with our patient. So palliative care will need a multidisciplinary team. It doesn't need only medical doctors. It doesn't only need oncologists, surgeons, internal medicine or other practitioners, but we need psychologists who will help the patient go through the different stages, from the diagnosis to the treatment to the end of life, or the different steps that can happen. So we also need to take into consideration the family. Yes, the family. Does the patient have a family? Does he have a social support? Which culture is our patient coming from? How is he managing the news that he has received? And also the spiritual part, because depending on his spiritual background, it can be a strength, something that we can use to motivate the patient. And the patient also can need a spiritual guidance, depending on his background. So it's important to be open to listen to the patient's needs in all the aspects, what we call a holistic approach. So we take into consideration all the different needs. And as we are making a care plan, we include all the different professionals. Also, the social workers will be needed if the patient has some financial issues or social issues, and they can help do advocacy for him, be it in the hospitals or in the community. Yes, so this is a slide that we usually use when we are talking about palliative care in our context, especially with the students. We tend to use this red and green diagram to show them that the palliative care will not only start when there are no when there are no therapeutic tools that we have, when the treatments that are curative or restorative are not working, because most of the time we tend to think that when a life closure is happening, the third green arrow, that's when palliative care starts. But instead, palliative care should start from the presentation, from the diagnosis, so that we start our therapies and our care pack with all the multidisciplinary team. So we have, we have different parts of palliative care. In the beginning, as the first speaker said, there are different therapies that can be used, radiotherapy, chemotherapy. She went very in details for that. So that's the first part. And as they try the different therapeutics to cure, for some patients, some therapies may either not work, or depending on the type of cancer, they may not be alternatives for curative treatment. And the patient may go into the stage of life closure. And life closure is when we don't have any therapies to relieve the sufferer or to improve the quality of life. And sometimes people may think that palliative care is mainly in that part between the life closure and the actively dying, when instead it starts way before. And now actually the palliative care should continue even after the death of the patient, to continue to take care of the family and do psychotherapy for the family, to accompany them after they've lost their loved ones. So the life closure is when, as the disease progresses, there comes a time of acceptance of the inevitability of the death. And it's a time actually when we can help the patient to attend to important activities, that can help him and the family get ready. And sometimes in African culture, sometimes it's not easy to communicate that either to the patient or to the family. And it's important actually to tell the diagnosis and tell the prognosis and the gravity of the disease to the family and to the patient, for them to be able to prepare themselves. Yes. And as I said, palliative care also should include the bereavement care to help the family get a psychosocial support and counseling after the death of their loved ones. So as I said before, palliative care is not only for someone who is dying or who is at life. It's not only end of life care, as they say. It should start from the beginning. It's part of an ongoing early care. And palliative care is not intended to delay death. It's not its primary goal, no. It's not only about pain. It's a holistic approach. Sometimes people tend to think when we talk about palliative care, we talk about, morphine and drugs that help us decrease the pain. Pain management is important, but not only physically, but spiritually, psychologically, and without forgetting the family. And all of that, all of our care, all of our aspects should be done in dignity. So in our Hippocratic oath as medical professionals, we we make an oath saying that we will relieve suffering, yes, and we will not hurt, but we will do everything in the benefit of our patient. So pain relief is a considerable part of a basic human right, yes. So as healthcare providers, we may not be able to help with quantity of life. We can't add days to life, but we can add life to the days. We can add quality to the life of our patients. When we do a holistic approach, when we do our approach, we have a multidisciplinary team with psychologists, with social workers, different professionals, different medical professionals. That's when we can offer our patient a dignified quality of care. Sorry. Yes. So I'm going to stop sharing. I have another slide I want to share. Let me stop here, and I'll share another one. Oh, I was also going to say that sometimes when we talk about palliative care, we tend to think that it's mainly applied to cancer, but it's not only applied to cancer. We can apply or talk about palliative care in other non-curable disease or other chronic disease. That's also important to mention. Give me 1 second. Okay. Yes, so I wanted to talk about psychosocial support and aspects in palliative care. Psychosocial support is very crucial for addressing the emotional, social, and spiritual needs of individuals facing life-limiting illnesses. So it involves providing counseling, having an open communication, offering resources to help patients and their family cope with the challenges of illness and end-of-life care. So this holistic approach aims to enhance the quality of life, reduce distress, and promote a sense of dignity and meaning during this difficult time. So when we talk about emotional support, patients in palliative care, end-of-life care, and even just sometimes at the diagnosis of a cancer, patients will have fear. They will have anxiety, and some may even have depression. So providing a supportive environment is very crucial to those patients. It's a heavy news that we are telling. So having a psychosocial support involves counseling therapy and therapy intervention to address the emotional distress. when we talk about quality of life, enhancing our patients' quality of life involves addressing psychosocial factors such as social relationships, hobbies, and meaningful activities. Encouraging open communication about personal goals and preferences is crucial. Remember, we said to know which person the disease has, not the disease the person has. Psychospiritual support is also important. Because some patients may want to explore, may want to have a chaplaincy services or someone spiritual to accompany them, have discussions about life's purposes, and support in facing existential concerns. So this aspect of care aims to provide comfort, solace, and a sense of peace, acknowledging and respecting the diverse spiritual perspective of our patient. So in palliative care, we'll have a biological or biochemical dimension that we can treat, but we also have a psychological dimension, a spiritual dimension, and a social dimension that we all take into consideration in our plan. Let me go back to my first presentation. Yes. So we say also that other disease may require palliative care, apart cancer. So terminal disease at an end stage or NCDs can require palliative care at the end stage. And where can a patient receive palliative care? So usually we are used to having palliative care services at referral centers. They should also be available at the closest place of the patient. So in district hospitals, in health centers, health posts, but also at home. The home-based care approach in palliative care is very important. And sometimes also through a combination of health facilities and NGOs. So the different steps of palliative care. So we'll start with living with a life-limiting illness. No matter the prognosis, in the beginning, it can be a good prognosis. And we try palliative chemotherapy or radiotherapy or curative chemotherapy and radiotherapy and curative surgery. And the prognosis may be good and we don't go to this stage anytime soon. But it can happen that we don't have these options of chemotherapy or radiotherapy when the disease is very advanced, when the cancer is at a late stage. And we'll do mainly symptom management. We maximize the quality of life. We maximize the community support and the psychosocial support. We will go then, when we don't have any more curative option, we'll go to the end of life care when it's not any more curative. And the patient may have weeks or months to live. And it can be done either in the hospital, in a hospice, or even at home, depending with the patient and the family choice, and also the conditions. If it's a patient with needing, for example, oxygen support, IV support, and the family may want the patient to go at home, and they can afford to have some help at home for that patient, then ideally that's what should be preferred. So terminal care would be when the patient is actively dying, and we will have mainly symptom management. Sometimes pain management would be what's most important, but of course we continue supportive management, be it IV feeding, oxygenotherapy for those who need it, and spiritual and psychosocial support for the patient and for the family. So I will share this slide of the palliative care. Okay, someone is writing on the slide. I don't know if it's me. I don't think so. Okay. So it's from our colleague, Dr. Christian Hizimira. So they are trying to do a palliative care district network to decentralize as much as possible palliative care unit throughout Rwanda. So each district hospital will have a palliative care unit, and it will have a nurse, a general practitioner. It can have one or two nurse. Actually, it's more than one nurse indeed, because nurses are usually more available and they're usually closer to patient. It should have a specialist per each district hospital, a social worker, a psychologist, of course, or a psychiatric nurse when the psychologist is not available for the psychotherapy. It can have a nutritionist and a physiotherapist. And the district hospital palliative care unit will be in charge of managing, mentoring the palliative care units at the health center levels. And in the same way, the health center will also help with, sometimes there will be a palliative care unit at the health post level, or sometimes there will be community health workers who are helping with taking treatment, like pain treatment, or let's say antiemetic treatment to patients who are in home-based care. And so far, all the district hospitals of Rwanda were trained in palliative care, and they were installing palliative care unit in all districts. And they've also trained nurses to prescribe morphine and other pain management, and they're really making efforts to make sure that patients are followed easily by the palliative care unit, and pain management treatment, mainly morphine, is more available. So as a small summary, I would say that the key in palliative care is teamwork. We need that all the team, doctor team, professionals, social workers, spiritual professionals work together to help our patient. Thank you very much for your attention. I'll give back the microphone to the chair of this meeting. Thank you.
Thank you so much, Dr. Mahoro, for the great presentation. Indeed, there was so much I didn't know about palliative care. I am grateful for the great presentation. Yes, I don't know if our third speaker is on. She's having challenges with her network. Is Miss Susan on? Okay. I think she's not yet with us.
Hello.
Yes, Alice?
Okay. Yeah, I was talking to Susan, and she was telling me that she has faced the network problem, and so she was suggesting whether it could be possible to use a direct call and connect her voices here on Meet. But I'm not uh, I'm not sure if there is anyone who can help. But the number she sent me is not working well. Maybe I don't know. You can try other measures.
All right. Unfortunately, I can't also get you properly. Your network is breaking. Maybe you could text me the information as we get into our Q&A session. Yes. So for now, I think we can get into our Q&A as we wait and hope that maybe network could be restored, or we can help with what you're trying to say, because I feel your network is breaking too. Timothy, I see your hand. I'll get to you soon. Yeah, so to our doctors, we're thankful for the information. It was very insightful. So at this point, we'll get into a Q&A where our students will ask us the questions they had prepared. So you for the students, I was kindly asking if the question is specific to a certain doctor, be sure to be more specific as you ask. And yeah, our first hand was from Timothy. Yeah, Timothy, the floor is yours.
Okay, thank you so much, Doctor, for that powerful session. My question is on the psycho-spiritual support. We all know that we are different people from different backgrounds. So how do we resolve these differences in our belief, in our values, when it comes to the management of some of these terminal diseases? My belief sometimes might be different from others. So how do we balance these differences in our religious values in terms of providing psycho-spiritual support? That's my question, Doctor. Thank you so much.
Thank you very much for that question, which is very, very important. Something that we come across every day in our practices. I remember as medical students, there's a course that we had, which was called community medicine, whereby we would go out into the community, see how people are living, appreciate their way of life in terms of their social beliefs, spiritual beliefs, and things like that. I personally learned how to appreciate that we all have different backgrounds, in that we cannot trash out someone's beliefs, but we have to appreciate that we've got different belief systems. That having been said, when patients come to us, we do not throw away their beliefs. As oncologists, we share with them the treatment modalities that we have seen working. Personally, that's what I do. I tell them, I've seen this type of chemo working, I've seen this type of radiotherapy working. And then some will say, but I've got this herb with which I got from a traditional healer. I've heard that it works and things like that. I explained to the patient that I cannot throw away your belief system, but I can show you patients who have done well with chemo radiotherapy. You can also bring me patients who have done well with that type of treatment you want to pursue. And then you as a patient, you decide how you want to be treated. I also explain to them that you cannot mix for example, herbal treatment with conventional chemotherapy or radiotherapy because it leads to excessive side effects, one of them being severe renal failure. So I explain to the patient what I know works, and then I give them the option to choose what they want with, explain to them mix the different treatment modalities. You have to choose how you want to be treated. At the end of the day, we have to respect the patient's decision. I think the second speaker also showed us that slide on Hippocrates Oath. We have to, part of Hippocrates Oath is to also respect the patient's decision. The patient has a right to decide on how they want to be treated. Then we as clinicians, we owe it to them to explain what we think works. But at the end of the day, it's the patient's choice. Like I said, that community medicine attachment helped me to appreciate why we have so many different belief system. And you'll be shocked to know that even among doctors, we have some doctors that we treat that refuse conventional chemotherapy, opting for some other forms of treatment. But personally, I've never seen them to work. The patients always come back wanting to get the conventional chemotherapy or radiotherapy or targeted therapy, whatever that we are used to. But the take-home message is the patient has a right to know, to information, and they have a right to the choice of treatment that they want. I hope that answers your question. Thank you. I was not talking to myself.
No, Doctor, we're listening to you.
Okay.
And I think you've answered very well the question. Indeed, respecting the patient choice is always what, I mean, the patient's will is what decides his care. And I would totally agree with you that what we can do is inform the patient about evidence available with the chemotherapy. And sometimes it can definitely be hard to convince the patient, especially when he believes in traditional medicine. But I would say that if the patient, for example, is a believer, be it a Muslim, Catholic, a Protestant, but has something to believe, sometimes you can even ask spiritual leaders to help talk with him and encourage him in his treatment. Yes, that's what I wanted to add. Thank you.
All right, thank you so much, Dr. Edith and Dr. Mahoro. Do we have any other questions? Students, Timothy, your hand is still up. I'm not sure if it's from the previous question or you have another question. Could you just confirm with me?
Yes, please. I still have one more question. Please, can I quickly ask before the end of session?
Okay, just a bit. Hold on just a minute. Do we have any other question before we give Timothy another chance? Okay, so we can go with Dr. Ishmael. Then after Dr. Ishmael, we'll get back to you, Dr. Timothy. All right, Dr. Ishmael, the floor is yours.
Can I go on with my question, please?
Just a bit, Dr. Timothy. I wanted to allow Dr. Ishmael to go before you, then you go after him. Dr. Ishmael, your hand is up. Is that a question?
Can I go ahead with my question, please?
All right, sure. Dr. Timothy, you can go ahead.
Okay, thank you so much. And one thing I believe in clinical research is informed consent. Do we also use this informed consent in cancer management or in palliative care before we provide all this palliative care, psycho, spiritual supports, and all other supports? Is there a need for us to obtain this informed consent, or we just go by a degree of expertise in cancer and related disease management? Thank you so much.
Thank you,
I'm done with the question. Did you get my message, please?
Thank you. I got the question. Thank you, Dr. Timothy. So in oncology, we ask for a written consent before we administer any form of treatment. Remember, these treatments are associated with a lot of side effects, some of them which can be life-threatening, and also getting the treatment is not a guarantee to a cure. So before we give any form of treatment, we go through a long session of discussing the possible benefits of the treatment, the possible side effects, and what to do in case of emergency. Then after that, the person is asked to sign any consent form, acknowledge the health of them, all the side effects and possible benefits, and that they want to proceed with the treatment. So yes, we make the patient sign an informed consent form before we administer treatment. Thank you for that question.
Seen a question in the commenter.
Okay, yes, Dr. Mahoro, there is another question in the chat box, which is saying, how effective is palliative care in improving the quality of life of patients with chronic and terminal illness in Rwanda?
Yes, thank you.
How effective is palliative care in improving the quality of health of patients with chronic or terminal illness in Rwanda?
Okay, let me give an example from the IHCRI team, the Center for Research and that is training actually palliative care units in Rwanda. So it's a story that happened almost 6 years ago, 6 or 5 years ago. It was in one of the referral hospital. It's a teaching hospital now. It's called Kibagabaga District Hospital. And there was a patient who had a bone osteosarcoma, and the patient was very young. She was like 16 years old. She was a student in secondary school from a rural area. And of course, she was diagnosed after almost 2 months of treatment. She came from a district hospital. Okay, she started having pain when she was at school, and then the tumor was growing. So between the time she left her home, went to the district hospital in her province, and was transferred later to Kigali, the capital city, where they did imaging and they did a biopsy, and they realized it's a tumor, and it's malignant. And at that time, the patient didn't have options for curative treatment, so it was only palliative care. And at that time, the patient, she was a girl, she was with the mother. But after 2 weeks of knowing the treatment, the diagnosis, the mother actually couldn't handle the news. And she left the girl in the hospital. So for almost 1 month, the girl was there alone. And the palliative care team was trying to reach out to the mother to explain that she should come and accompany the daughter. And so the team, a nurse and a social worker and a therapist, so 3 people went to their home, to the home of the girl, because they tried calling on the phone, it didn't work, to explain again to the mother. And unfortunately, actually, when she was about to leave the hospital, she didn't even inform the personnel of the hospital. She just left, and they realized actually she was not coming back for the girl. So in that simple example, you can see that even though there are different efforts to help the family, sometimes it can be something very hard. But fortunately or unfortunately for the girl, the mother was able to come back almost 1 week before the patient died. So real efforts are being made so that palliative care units are really functional and helping patients. Thank you.
Thank you so much, Dr. Mahoro. I don't know if we have any more questions. Students, we're just allowing for 1 more question.
Okay, thank you.
Any last time?
Yeah, I can raise 1 question.
Okay.
Are you hearing me?
Sure, we can get you.
Yeah. Thank you for these nice presentations. I would like to ask a questions about my question also goes to both speakers. I want to ask how is accessible of cancer treatment like chemotherapy, radiotherapy, and the surgery for patients both in Zimbabwe and Rwanda, because I used to see maybe those cancer treatment I found, for example, here in Rwanda, it's not available on all hospitals. They are available in some hospitals, and how is the availability, and also how is the cancer progress or the cancer treatment are just successful here in Rwanda and also in Zimbabwe. Thank you.
Thank you very much for the question. Accessibility of cancer treatment in Zimbabwe is mainly at the central hospitals. So there are currently 2 central hospitals that offer cancer treatment in the public sector. There are plans to open a 3rd hospital in one of the provinces. We definitely need more hospitals to offer this cancer treatments. But like I said in the presentation, currently the government is collecting tax from sugary drinks. So that money is being channeled towards the improvement of cancer treatment services in the whole country. In terms of availability, we have radiotherapy in those two places that I mentioned. The challenge is that sometimes the machines break down, and sometimes it takes a bit longer to repair the machines. So that ends up causing long waiting times for patients to get radiotherapy. Fortunately, at the moment, we have procured about, I think there are 4 or 6 new radiotherapy machines. So hopefully that will reduce the waiting time for patients who need to get radiotherapy. Chemotherapy in general is available. The basics are in the public hospitals. It's the fancy drugs which are very difficult to get, mainly because of the cost. But we do understand that most of our patients cannot afford some of these fancy drugs anyway. But in general, the basic drugs are available. Here and there, we run out of supplies, and patients can buy these from the private sector. The main challenge with our patients is health insurance. Most patients pay out of pocket. So when you are paying out of pocket, the treatment becomes very expensive. So some people may not afford the treatment, and in that case they then have to go through the social welfare, make sure they get the assisted medical treatment later, so that they can access free healthcare. But that takes very long, so it's a challenge for our patients. So what will really help in our governments is this universal health coverage. At least it can enable a significant number of patients to get the treatment on time versus getting the treatment later on when the disease is advanced. But ever since I became an oncologist, I've seen things improving. I think with the collaboration of the collaboration between other African countries is helping Africa as a nation to improve the way we manage our cancer patients. I know is it Kenya? I think it's Kenya, where there was an act of parliament which they enacted that enabled them to centralize all cancer and related services in a central location, whereby they plan things like prevention, research, cancer treatment. I think they formed what they call a National Cancer Institute, which directs cancer activities in most of the country. And most of the countries in Southern Africa are trying to copy or learn or adapt from what they have done. So talking from Zimbabwe, I think we are improving our services. It's taking time, but there are definite steps that we have seen. So I think the future is quite bright for us as Africa. I also mentioned the African Cancer Coalition, whereby we use treatment guidelines which followed the NCCN, but they are adapted to an African setup where, for example, in a high-income country, you would use a certain drug, but if you are in a low to middle-income country, those guidelines will show you other drugs that you can use as a substitute, and these have comparable response rate to the drugs which are advocated for in in high-income countries. So at least that is enabling our patients to get affordable treatment, which at the same time is standard treatment, but is not here to that they would otherwise get in a different setting. So yes, we have challenges, but I think we are working on those challenges. And if we continue working on them, we will definitely get somewhere. We have better outcomes to our patients who have cancer. Thank you.
All right, thank you so much, Dr. Edith. Yeah, it's so unfortunate that our survivor couldn't make it due to network problems. However, I feel like I'd like to acknowledge her in absentia. So our third speaker was going to be Ms. Susan Katuruza, a cancer survivor, specialist renal nurse, and portrait artist. Her willingness to come and share her story and also to encourage us was something that we did not take for granted, and for that I would just like us to give her a round of applause in absentia. Yes, so in closing, we're going to have closing remarks from
Sorry.
our team. Yes, Dr. Mahoro.
Yes, I just wanted to briefly answer on Ismail's question on the cancer treatment centers we have in Rwanda. So we mainly have one private center, and I would say it's called Butaro Center of Excellence. The good thing, the Butaro Cancer Center of Excellence, it's a non-profitable center. It belongs to an organization called Partners in Health. And they are also pioneers in Rwanda for cancer treatment. They have more than 10 years, and they provide radiotherapy and chemotherapy. And they treat both adult and children. And one of the good advantage of that center is that they provide free treatment. Free treatment for everyone. As you can imagine, that will make them have a huge list of patients. Since they only work in the northern province of Rwanda, accessibility to their place can sometimes be a challenge to cancer patients who are weak. So the other cancer center we have is the Rwanda Cancer Center. It's at the Rwanda Military Hospital. It's in Kigali. It's the one that also gives radiotherapy and chemotherapy. Other centers like the University Teaching Hospital and the King Faisal Hospital, University Teaching Hospital being a public and King Faisal Hospital being a private, they mainly give chemotherapy. And as Dr. Edith already said, cancer treatment usually is very expensive. So sometimes in the private, it's not easy to get for the patient. And sometimes what we have also is a stock out of treatment. Because we have I would say a long queue of patients, sometimes we have stock out, and that delays the protocol the patients were having, and it will contribute to a bad prognosis. So thank you very much. You can continue with the closing remarks.
All right, thank you so much, Dr. Mahoro. Yes, so in closing, I'm just going to call upon Ishmael to come and give closing remarks on behalf of the President, Alice Niyo Buhungiro.
Thank you. Good afternoon again. As we come to the end of this important discussion about advancing cancer survivorship, I would like to extend sincere appreciation to all speakers, both speaker from the Zimbabwe and the speaker from Rwanda, even if we met with the obstacles of not getting our third speaker, Susan Katuruza. But we would like to express our appreciation to you all for your greatest contributions and active engagement. So today's discussions has remind us that the cancer and the palliative care goes hand in hand, and that cancer does not end with diagnosis or treatment. So survivorship is an essential part of the cancer journey, one that require continued medical support, psychological cares, you said, social inclusions, and other policies that promote quality of life for everyone. So, on the behalf of all participants, I would like also to express gratitude to Internal Health Cancer Research Initiative Rwanda in collaboration with UNZAMEDISA, which is the Association of medical students from Zambia, also for organizing these meaningful sessions and creating platform for knowledge exchange, advocacy, and also corrective action toward improving cancer survivorship. So may the ideas, maybe I would like to also to ask the participant and all students and others. So may the ideas shared today inspire us to strengthen the research, enhance patient-centered care, expand access to services, and continue building systems that empower cancer survivors to live healthier and more fulfilling lives. So I would like to thank you all for your time, commitment, and dedications. We look forward to a continued collaborations and meaningful impact in advancing cancer survivorship. Thank you. Safe journey to everyone. Thank you again. So thank you for participating. Have a safe journey and also good evening. Thank you.
Thank you very much. Thank you.
Thank you, Doctor.
Thank you so much, Dr. Edith and Dr. Mahoro and all the students. Yeah, we can log out. I hope we meet some other time again.
Thank you. Thank you, moderator.